Welcome to the ACO Show, a podcast about the American healthcare system and some of the people who are trying to make it better. I'm Josh Israel, joined by my co-host, Sean Cavanaugh. Hi, Josh. So we're talking about some of the people who are trying to make it better. In this case, we are going to North Carolina.
Yeah, we had the North Carolina treasurer on. You might be wondering why the treasurer's here, but he happens to administer the state health plan for state employees, retirees, and their families. And they're trying something new and different there.
And they have the unique advantage of caring for these patients for years and years, so they don't have the churn that other essentially insurance providers have to deal with. What are some of the other features that you think might work here?
Well, the thing that jumps out is they're making a heavy investment in primary care. So they're working with 3 clinically integrated networks that are very primary care focused, including Aledade physicians, investing more in them, giving them some regulatory relief from prior auth and other things. And then trying to adjust benefits somewhat to engage the consumers more so that they see the advantage of, one, a longitudinal relationship with primary care, but also to shop somewhat in their healthcare benefits.
Yeah, we're glad to have the treasurer join and try to explain it to us. And I'm also glad to have Alex Mullineaux, who is Aledade's market president, who works directly with the practices. And it sounds like the physicians and other clinicians down there are excited to give it a try.
Yeah, Alex, I think you'll hear reports that the North Carolina physicians are really excited about this program. So we'll learn more about it.
All right, let's hear about the state health plan's preferred provider strategy in North Carolina.
We're joined today by North Carolina Treasurer Brad Briner. Welcome, Mr. Briner.
Pleasure to be here. Thanks for having me.
Also joining us is Alex Mullineaux. Alex is a market president at Aledade, particularly for North Carolina, but a broader region, right, Alex?
That's right. Thanks, John.
Good to have you. We're going to talk about some innovative things you're doing with the state health plan in North Carolina. But Brad, can you first just tell us a little bit about the state health plan? How many people are you covering?
Sure.
What's the nature of the program?
Yeah, the state health plan is 760,000 North Carolinians. That's not quite 7% of the state is on the state health plan. It covers all of our hardworking state employees, both active and retired. And so we have a huge role to play in keeping North Carolina healthy, particularly those who protect and serve our state.
So, Brad, the state health plan's board of trustees recently approved something in phase 1 called its preferred provider strategy. And that's what we were hoping to talk about today. And it's an arrangement with 3 clinically integrated networks, including Aledade.
Right.
Can you describe what is this strategy and what it was trying to solve?
Sure. So let me kind of go back for a second. I'm not a doctor. I'm not a healthcare guy. I'm not a healthcare policy expert. I've learned a lot in this role over the last year and a half, and certainly the year before that running for office. But I think bringing basic business concepts to these conversations is really important. And that's led us here. I've always wondered why we didn't align the incentives between our members, between the providers, and between the plan itself. Because if you do that, you set up a situation where things age well. You could set up a system where everybody doing the right thing means everybody wins. And that's what we're trying to do at its very basic level. And sometimes we forget the basics, I think, in a lot of worlds, but particularly in the healthcare world. So that's the goal, is how do we set up a situation where our members, our providers, and the plan itself benefit from coordinated action? It begins with primary care. It begins with unconflicted primary care, where we can lean in to those providers who only have our patients' interests in mind. We can pay them more. We can get out of their business more by removing prior authorization constraints and other things. And we can share savings. And we can do that because we know that they only have our patients' best interest in mind, not some other referral incentive that we don't see.
So in another conversation, as treasurer, I've heard you say that the state of North Carolina in 2025 faced a revenue problem, but that coming into this new year, you thought you had more of a cost problem. Can you tear that apart for us?
Sure. So over the long run, the state health plan has a basic, kind of simple problem, not easy to solve. And that is that revenues into the system go up 3% a year and costs out of the system go up 6% of the year. You don't need to have an MBA to understand that that doesn't work. And so the question is, how do you solve both? And on what time scale can you solve either? Really, revenue is always the quickest answer to any business problem. You can raise prices tomorrow in almost any business. And so it was in the state health plan. We needed more money in the system in 2026. And trying to change your cost infrastructure is something that you have to do, but you can't expect to do really quickly. Changing your premiums, asking General Assembly for money, asking providers to take less money, you can do that reasonably quickly. So we focused on revenue to solve the 2026 problem, but we can't make this all about revenue in the medium and long term. We've got to solve the cost problem and bring that 6% down to something like 4, bring revenue up to something like 4, and all of a sudden we've got a sustainable business, because that is the ultimate point for all of our members, is to have a wonderful benefit, but also to have it in the future, not just today or tomorrow.
So Alex, the treasurer is talking about a strategy where people are in alignment, where primary care matters. That rings a bell. What did Aledade need to do to be ready for a partnership like this?
Yeah, it's a great question. We're taking a lot of lessons from our existing relationships with large payers like Blue Cross, United, Aetna. We've been in relationship and working with them for a number of years to manage their members. And that includes things like reducing unnecessary emergency department visits, referring patients to high-value specialists, managing chronic conditions such as hypertension and diabetes. So we've already had a lot of experience doing that, and we're prepared to do this work and take it to another level now in this partnership, mainly because we're working now directly with the ultimate payer, which is the employer. And that's really exciting.
Brad, as you heard Josh, like when you talk about alignment, that's something near and dear to the hearts of Aledade. But tell us, what's the state employee or his or her family going to experience? How is what happens this year different from what's gone on in the past?
There's a basic kind of cultural change in how people need to think about healthcare. And that's a broad statement across probably the entire United States, but we're trying to solve the state health plan of North Carolina's issues. We need them to be comfortable asking what things cost and what kind of value they get out of it. And when they become shoppers, that is when we get to a position as a state health plan where we all win. And so ultimately that is the goal, is to try to arm people with that data, with unconflicted advice, so that they can go make value judgments for themselves. That will empower them to take care of their health, short and long term, in ways that they simply aren't right now. And so that's the ultimate design of the plan.
In the past, there has been other attempts to solve this problem, including enacting across the board provider rate cuts, and the hospitals weren't too happy about this.
Right.
How might this strategy be different?
Yeah, so we had a program called the Clear Pricing Project, and it was admirable in intent, but it was deeply flawed in design. What it did was it offered people a fixed percentage of Medicare if they would sign up for essentially a preferred steerage program. But it was an offer, not an obligation. So what ended up happening is everybody who was getting less than that percentage of Medicare opted in, and everybody who was getting more than that percentage of Medicare already declined. So we ended up with higher costs and ultimately accelerating higher costs. What we did learn, though, which was really important, and we already kind of knew it, but now we specifically know it, and it's a design tool in a lot of what we're doing now, is that our members are extremely cost sensitive. What we saw is that in primary care world, something like 30% of our members switch primary care providers for a difference in copay of $30. So this is an important relationship in everyone's life, their primary care provider, and for what is a reasonably modest sum to switch primary care provider for that tells you about the cost sensitivity of our members. And that is, again, a design principle and everything else that will come next. It's if we can encourage people through sharing savings in everything else we do, then they will play ball. They will go to the better provider. So that's ultimately going to be different about this. The elective nature of the Clear Pricing Project was ultimately a challenge. We are now using elections at the member level rather than the provider level to drive volume.
And Brad, I believe, as you said, you're going to be working with 3 clinically integrated networks across the state. What are they going to experience? How is their role different than what it's been in the past?
Yeah. So first, scale. We are a big program. We have a lot of members in a lot of places. And so the access that they allow us and that they will accommodate or need to accommodate is really important. It will provide them with more scale to their business, which is generally good. 1, 2, they will benefit from much lower red tape. We are partnering with these practices because we believe they are unconflicted and they do a great job for our members. And so our desire is to get out of their way and let them do it. By and large, we should be able to reduce prior authorization by an enormous amount, 2/3, 3/4, which will allow them to actually go about their business instead of filling out forms for us and having to negotiate with the insurance company. And then finally, we will get to a point where we are sharing savings with them. Where if they can help us steer our members towards better outcomes for less cost to the plan and less cost to the member, we are happy to share that. That's how you make the recipe work in the medium and long term. And so those will be the changes experienced by those providers. And I think they're all positive.
Alex, let me ask you a little bit more about prior authorizations there. I hope to never fill out another one in my life. The friction and unpleasantness of them is sort of how they work. But I do understand that they lead to savings. Do you have any concerns that if we remove those from the Aledade physicians and others in the networks, it could lead to higher costs?
Yeah, my experience is that it doesn't, but here's two main reasons. One is, and Brad, you mentioned this, pairing up the financial accountability and this greater freedom creates an opportunity for physicians to practice medicine the way they see fit, which is absolutely what we're looking for. And they tend to be, in those cases, when that pairing happens, they tend to be very good stewards of financial resources because they have that skin in the game. There's also more engagement in providing appropriate care in appropriate settings and helping patients understand their cost obligations. Second reason is in North Carolina specifically, primary care only makes up about 5 to 6% of total healthcare spend, which is pretty close to the rest of the nation, but it's way under where most studies have shown that where it should be. And so in peer-reviewed studies, we've seen 10 to 12% is probably a tipping point a lot of times for that wellness journey that these members are on. And we know that more better primary care is a true win-win-win. It's good for patients, it's good for physicians, and for society is what we find.
Let me just say that back, that more primary care, more spending even on primary care is probably good for overall costs and for patients' health. Is that right?
That's what we've seen. Yep.
Brad, is that the thesis underlying this new program?
It is. I mean, the other related piece of that, the old ounce of prevention, pound of cure argument, one of the other structural advantages of the state health plan, which people don't always think of it as one, is that we have an indefinite time horizon with our patients. We don't have to guess as to whether they're going to be on the plan tomorrow. They are. We've promised lifetime healthcare, folks. So it'd be a little silly to go get another provider. That allows us to take a long-term view of investing in them. And that's another piece of this, is thinking really carefully about the long-term interventions we want to make on behalf of our members so that we can keep them healthy. And primary care has a huge role in those kind of endeavors.
That is a unique advantage, knowing that you'll have the patients for a long time.
It is. So the GLP-1 conversation is an example. We are not covering them currently. It's a goal to get back there. And in part, that is a goal because we know the long-term difference it will make for our members if we can do it responsibly.
So Brad, in many respects, you're an employer, very large employer.
Yeah.
The more typical path of an employer that are self-insured is to work through a TPA. And then when they're unhappy with the TPA, then they hire a bunch of benefits consultants and they try a bunch of stuff. You've taken a bold move as like, no, we're going to design our own program and we're going to work directly with providers. And there are other efforts like this around the country. But you're a particularly big employer. You said 7% of North Carolinians. Do you foresee, if and when you're successful, that there's a pathway for other employers to do this in North Carolina?
I would hope so. Zooming way out on healthcare in general, the definition of insanity is doing the same thing over and over again, expecting different results. And that seems to be what we do in the healthcare ecosystem. More money is not always the answer to this question. I do wonder if the state health plan circumstances are so unique that it's not replicable to other programs, that lifetime benefit actually works to our advantage in some ways. And so I don't know. The cost sensitivity of the average member is extraordinary for us, and that is a benefit in the way that we've designed this. So I would think that some of these principles are universal, but I don't know that for sure because we do have some unique attributes.
Alex, can you talk to conversations you've had with physicians in the Aledade network about how they perceive this, what they expect?
Yeah, I don't know exactly what I expected, but it is incredible how popular and how excited physicians and practices are about this model. Not only because they're partnering directly with the state health plan, but also because it shows that they care deeply, that the state health plan cares deeply about fortifying primary care in the state, and that is a priority. And for primary care physicians, that's what they're looking for, are somebody to take notice that they're the ones that are driving the better care and the wellness in the community.
Brad, at the top of this conversation, I think you or Josh referred to this as phase one, which implies that there's future phases as well. Where do you think this goes?
Specialty care. So that's the next step, is once we get the architecture in place to align incentives in primary care, we've got to go up the chain into specialty care. And you can do that in a number of different ways, where we want to make sure that our members are aware of the value proposition of the service, have access to unconflicted advisors, and benefit from making a great choice. So those design principles continue up the chain into specialty care. And so hopefully we'll see that in maternity, in dermatology, imaging, on and on.
Well, Treasurer Briner, you said at the outset, you're not a healthcare guy, but I got to say, you're one of us now. Welcome to the tribe. There's no getting out once you're in, and we welcome you among us.
Yeah, I always joke I ran for a finance job and I got a healthcare job.
With Treasurer Brad Briner of North Carolina and Alex Mullineaux, Aledade Market President in North Carolina. Thank you both so much for joining us to talk through this exciting program.